Hello, and welcome to today's presentation on the certification of patient decision aids in Washington State, a round 2 and request for submissions. My name is Laura Pennington, and I'll be the moderator and facilitator for today's presentation. But before we get started, I would like to let you know that we'll be taking questions at the end. However, please feel free to submit your questions using the chat box throughout the presentation. So before we get started, I'd like to announce today's presenters. First up will be Dr. Dan Leffler. He's our Chief Medical Officer at the Washington State Healthcare Authority. And then Karen American, who's a consultant on our state shared decision-making project and a JD. And then myself, Laura Pennington, also from the Healthcare Authority, and I'm the Practice Transformation Manager for our Healthier Washington initiative here in Washington State. So the objectives for today's presentation. So we recognize that many of you on today's webinar are familiar with our process in Washington State and attended last spring's presentation. So this will be a bit of repeat information for you, so please bear with us as we get to the details for this round. So the objectives for today's presentation will be a brief overview again of why Washington is certifying patient decision aids, a discussion about the updated criteria that will be used to assess the decision aids submitted during this process, a brief overview of the process used to submit decision aids for certification, our review and approval process, and then information about our next call for PDAs, including our priority subject areas, the timing, and cost. So I'm going to turn it over to Dr. Leffler to provide you with the background as to why Washington is certifying patient decision aids.
Great, thanks, Laura. Yeah. So, and just wanted to provide some background on shared decision-making and the importance of decision aids to that process and sort of the overall strategy of the state is taking with respect to trying to encourage the use of shared decision-making with certified decision aids in practice. First, you know, as somebody who's practiced for a little bit over 20 years. You know, I think we all recognize that I think really the nature of how we provide care as practitioners has been changing, and really recognizing the importance of the patient as partner, and shared decision making is really an approach that you know, that I would say honors that partnership, and which really allows the patient in conversation with a clinician to express their values, and then really for the clinician to be an interpreter of data in light of a patient's values, so that the decision that is reached, that in terms of what a patient decides with respect to how they want, what care they want, really reflects their values and a good understanding of the risks and benefits and you know, full breadth of considerations that they need to be thinking about in deciding to have something done or not have something done. So that's really what shared decision making is about. Next slide. So the decision aids are a tool that can facilitate optimal shared decision making, and they're a tool that provides information that allows an engagement of the discussion, and they can be a very important tool in that way. Decision aids can be a written document, they can be a link to a website, they can be videos, there can be associated visual aids, so that, you know, the medium through which they're delivered it can be varied. Next slide. There's very good evidence that oops, I think we just skipped one. Can we go back? There we go. There's good evidence that the use of decision aids in a well-conducted process of shared decision making actually improves the quality of care. It improves patients' knowledge of options. It leads to more accurate expectations around benefits and harms, and most importantly, it leads to a congruence between a patient's values and the nature of the decision that they are making. Next slide. So Washington, through its Healthier Washington work, has broadly recognized the importance of patient engagement to achieving the triple aim. And in terms of promoting patient engagement, shared decision making is a key process, and really a way to achieve truly patient-centered care. And so the importance of shared decision making to patient engagement and the evidence around it, and the evidence around the use of well-done decision aids to promoting patient engagement has actually been recognized in Washington law. That and we're going to talk more about that in just a moment. But the use of shared decision making with certified decision aids is afforded special status in Washington law, and that's an important way in which the state is helping to promote shared decision making in practice. Next slide. There also, as people might be aware, actually at a national level, there's been a lot of activity around shared decision making. It is actually called out specifically in the Affordable Care Act, and actually in the Affordable Care Act there's discussion of certifying decision aids, but there was never any money appropriated for that work. CMS has in various ways recognized the importance of shared decision making, and I think one of the most explicit is in 2015, Medicare actually came out and said that it would pay for shared decision making in the context of decision making around screening for lung cancer. Next slide. So, just want to talk a minute about why certification matters in the state, and so as I mentioned, through Healthier Washington, we are promoting strategies to improve patient engagement in care, and that shared decision making is a key component of achieving that end. Our hope is that decision aids that are used in the context of shared decision making will be used more broadly. And as they become, as their use becomes broader and sort of gets more and more integrated into practice, it's obviously really important that those aids truly be high quality and evidence based. And moreover, because Washington affords special legal protections to clinicians who are using certified decision aids in the context of shared decision making, obviously it's that's a high bar that we want to be getting over in terms of the quality of this interaction and the quality of the decision aids that are brought to bear in that context. So that's really the reason this matters for us. In addition, we're actually now working with and collaborating with the National Quality Foundation, NQF, on taking what we're developing here and perhaps creating a national model. So two reasons why it's important. Next slide. There are various ways in which we're trying to drive shared decision making into practice with well-done decision aids. First, the BRIE collaborative, as that some folks might be aware of, the BRIE Collaborative is a statewide collaboration of various stakeholders who come together around looking at areas of high practice variation or high cost and making best practice recommendations that then HCA works to disseminate. Those BRIE Collaborative recommendations have often included a recommendation to use shared decision-making and in particular to use shared decision-making with state-certified decision aids when they're available. We at the state, the Healthcare Authority have launched 2 accountable care programs with 2 different networks for PEB employees, and in that work, we're working very closely with these networks to implement pilots of shared decision-making in maternity care using certified, when possible, using certified decision aids. And then we have done likewise contracting for joint replacements, a center of excellence, which similarly incorporates an element of shared decision making, and then we also have our practice transformation hub through our CMMI supported work, which will be promoting shared decision making in the community. Next slide. So that's about a bit of background in this state, why shared decision-making is important to our promoting patient engagement and the relevance of well-done decision aids to that. In my comments, I did mention that Washington affords special protection to clinicians who use certified aids in the context of shared decision-making. And I wanted to turn it over to Karen Merrican, who actually was very involved in the development of the law that provides that protection, to explain a bit more background, history, and explanation on how the law works. So, Karen.
Great, thank you. So I'm going to talk a little bit about the statutory underpinnings in Washington State for shared decision-making. This statute, RCW 770.060, is the primary place in Washington law where shared decision-making is mentioned. It's the section of our law that's most pertinent to this discussion today. So that law is important to know about because it defines shared decision-making and patient decision aid. It, as Dan said earlier, affords shared decision-making following state requirements, a higher level of protection and informed consent liability actions. As it does that, it recognizes both state and nationally certified patient decision aids, and critically, it enables the Healthcare Authority's medical director to certify decision aids, which is what we're going to be talking about in more detail today. So next slide. Okay, so first I wanted to talk about the statute and its role in informed consent litigation. And before talking specifically about the statute, let's talk a little bit about the overall legal backdrop, which is not, I think, the primary reason that many people are interested in shared decision-making. There's a lot of reasons outside of liability concerns why shared decision-making using high-quality decision aids is a great thing for patients and for providers. But in terms of liability, let's talk about that for a minute. So it's widely recognized that poor communication and lack of information are the most commonly reported sources of patient dissatisfaction in healthcare. Extensive evidence has confirmed that communication failures are strongly correlated with medical malpractice litigation. Informed consent also is often a secondary issue in a malpractice case that has the potential to add to liability by increasing the likelihood of a claim, the magnitude of the associated demand, or the frequency of payments. Many liability claims occur because patients and their families fail to recall what has been communicated to them. And studies also indicate that patients and physicians don't look at risk, particularly surgical risk, what matters, what is material to them, in the same way, often with many patients being more conservative in outlook than their physicians. So an established rapport between patient and physician based on solid exchanges of information can prevent patient disappointment from ripening into a claim in the first place. If an informed consent action is brought in Washington State, the prior use of shared decision-making properly documented provides substantial protection from an adverse finding of failure to provide informed consent. And this slide illustrates why. In the case of shared decision-making meeting the requirements of our statute, the patient would have the burden of rebutting the patient's prima facie case, we call, that's established by documented acknowledgement of shared decision-making by clear and convincing evidence rather than the preponderance standard that typically applies in civil litigation. The difference isn't trivial by any means. The preponderance standard is more likely than not. The clear and convincing is substantially more likely to be true than not true or highly probable. That raises the bar in litigation substantially, but it does it for a reason. It does it because there's a well-documented use of shared decision-making using a high-quality certified decision aid. Next slide. I just want to underscore this. The enhanced protection isn't for distribution of a decision aid, however well documented. The enhanced protection is for a process of shared decision-making between clinicians and their patients that is backed up and supported by use of a high-quality decision aid. Next slide. So the statute's also critical because it contains these definitions. Here's the definition of a patient decision aid. No surprises here. I think the important piece are the emphasis on a balanced presentation of the condition and treatment options, benefits and harms, including, if appropriate, a discussion of the limits of scientific knowledge about outcomes for any medical condition and or procedure. And, next slide. I highlighted this provision because this is the one about certification, and the language down the bottom is what we're talking about here today. So decision aid has to meet the definition above, and it recognizes the medical director of the healthcare authority has independently assessed and certified based on the International Patient Decision Aid Standards, which is the source and of our criteria here in Washington. You can also see that this definition allows the Washington state to recognize national certification should that occur, and should the medical director recognize that it meets Washington state law. Next slide. So this is just a slide that I provided. I'm not going to go through all of it, but this is what Washington law provides that has to be documented and done in order to claim the legal protection in Washington. And I highlighted one of the sections because it talks about what needs to be in the patient decision aid and the process here in Washington State. And if you go to the next slide, please. This is the language. So the acknowledgement of shared decision-making that needs to be documented has to include a brief description of the patient decision aid or aids that have been used to address the need for high-quality, up-to-date information about the condition, including risks and benefits of available options, and, if appropriate, a discussion of limits of scientific knowledge about outcomes. The decision aids are used in part for values clarification to help patients sort out their values and preferences, and as a means to help support guidance or coaching and deliberation designed to improve the patient's involvement in the decision aid, in the decision process. So I just wanted to highlight that backdrop to give you some idea for why the criteria are what they are in Washington, which we'll get to in the next part of our presentation. Next slide. So with that, I'm going to turn it over to Laura Pennington to talk about our certification criteria.
Thanks, Karen and Dan. So as you've heard both Dan and Karen talk about, part of our review process involves looking at the patient decision aids that are submitted and comparing them against a standard set of certification criteria. The certification criteria that we use in Washington State are based on criteria that has been established by the International Patient Decision Aid Standards Collaborative. And so we built off of about 10 years of research that group of folks worked on. And then we also pulled in many stakeholders from across the state as well as across the country and really looked at what's important for Washington State. And that's the criteria that we landed on. We used this criteria in our first round of review, but also, as Dan mentioned before, NQF is working on a national certification process. So based on some of those conversations, we updated the certification criteria to include 2 additional pieces of criteria, which we'll talk about in a second. And so we also want to mention, as many of you know already, that this work was made possible from a private grant from the Gordon and Betty Moore Foundation, who without that, we wouldn't be able to have developed this certification process. So the criteria, pretty much in brief, and I know many of you are aware of this already, is amenable to yes or no scoring. The review is based on the PDA itself, as I mentioned, as well as the accompanying application materials, including evidence tables and information on the developer and the developer practices. And the criteria also is probably going to be adjusted over time as the ABDA standards change and evolve, and as well as we gain experience with certification, which we did through our first process. The application also requires additional information that may be used to revise the initial criteria, which we learned through that process as well. But we use that additional information not necessarily to pass or fail, but that additional information can be used to at least better understand the processes the developers use to develop that patient decision aid. So I mentioned the updates to our 2017 criteria. One of the important conversations that occurred at the national level was around supporting readability levels and also plain language guidelines and health literacy skills. That was a conversation that we also had within our state that we felt was very important. But the first round, we didn't require it as a pass or fail part of our required certification criteria. So because of the recognized importance at both the state and national level, we decided to add it to our required certification criteria for 2017. So I'm not going to spend a lot of time on our application process because overall it hasn't changed that much from last time. But I did kind of want to briefly walk through it for those of you who are new to this process. But basically wanted to talk really quickly how the application is structured. We've made some updates, mostly around form and function. We know we had some difficulties with the application itself last time. It's still going to be interactive PDF. It's going to be available online. As I mentioned, the PDA must be the criteria. There's criteria within the application, but there's also additional information that we're asking with the application as well. We're asking you to submit the decision aid along with the entire application. The criteria is within the application, or within the PDA itself, as well as within those additional questions that we're asking. The application is divided into sections that list. The application is divided into sections, and each section of the application lists the applicable certification criteria as well as calls out additional information that's required, and we also require a full and complete response for each section. So the application packet, at least initially, will be available online as we did last time and can be downloaded for you to fill out and submit in a variety of ways, depending upon the format of your decision aid. If you're not able to submit your decision aid online in an electronic format, you can also mail it to us as well. So as I mentioned, the application is in 3 parts. Part 1 provides the background information about the application and a general overview of the decision aid, including the title, topic area, educational content, target audience, all formats, alternate language, revision date, and process for updating. That hasn't changed at all. And Part 2 is the certification criteria scoring sheet, which is a checklist that the developers use to check the PDA content against specific certification criteria within the PDA itself, including the location of the criteria within the PDA. We found this section of the application to be very useful to the review panel during our first round. This does put the burden of responsibility on the developers to show us how they feel that the criteria stacks up against their decision aid. And so the review panel was able to look at that and determine where they needed to find that specific topic area located in the decision aid, which reduced some of the time that it took, but on the other hand, it also helped make those parts in the certification criteria really relevant and understandable to the review panel, who otherwise had never seen these decision aids. So then Part 3 of the application, similar to like last time, provides that additional information about the process used to develop the decision aid, including funding sources, disclosures, attestations, and any additional supporting evidence, including field testing, readability, and health literacy, which I mentioned before, and evaluation practices. Some of that information is still informational, but we're still requiring you to fill out the application in full so we could really understand the process that was used by the developers to develop the decision aids. So one thing that I really wanted you to understand that I feel like we didn't really do a good job up front last year of notifying you of is that the Healthcare Authority is subject to the Public Records Act. So when submitting application, including the actual decision aids themselves, we really want you to understand that. So if you as a developer want to protect any proprietary information that's included on the application or in the patient decision aid itself from disclosure, the information must clearly be identified by the submitter as proprietary information. That means that all pages must be marked confidentiality or proprietary on each page in the lower right-hand corner. It doesn't mean that we get out of actually disclosing that document if in fact a public disclosure request is received, but it does make it more difficult for that to be released. They have to go through a couple different requests to do that. We can give you more information about that process, and we'll also include this on our website as well. So again, looking at using a similar process that we did last year, when we receive the submissions, we do an initial review for completeness, and then we determine if it needs to go out for expert review of the evidence. We convene a review panel by members of an advisory panel, which includes experts in that topic area. One thing that we learned this year is it was really important to have members of the maternity field, the OB field. We really needed that expertise. But we also needed people who really understood the criteria and what the criteria meant. So it's really important that we do appropriate training up front of that review panel. And so I'm going to walk you through really briefly because this is a kind of a big visual framework, but I mentioned that. The completeness, the evidence review, which is at the discretion of the medical director, and the review by members of the advisory panel. So once it comes back, excuse me, once it comes back from the review panel, per our legislation, as Karen mentioned, our Chief Medical Director has the final authority to make the final decision. He can either choose to approve it or decline it for certification or ask for additional information from the developer, in which case we would send it back with those questions specific to, as we did in one case this past year, specific to criteria where we felt that maybe we needed additional information to understand how that criteria was met. Once it's approved, we post a link to the information, the developer's information, as the developer would like us to post it on our website. We got a lot of questions this year about where's the PDA? We want to see the PDA. We know that some of the PDAs cost, so it's really helpful if we at least get contact information so people can contact the developers who they're interested in seeing at least a demo of those decision aids. And if, let me go back one more. If we do request additional information, then we'll take a second review and look at the decision aid and then make a final decision to either approve or decline. So this year we received 6 total submissions. Of those 6, 4 were approved initially, 1 was sent back for reconsideration, and 1 was declined. So generally, certification is effective for 2 years, and developers have the burden of keeping the information updated. As research changes and information changes, we ask them to resubmit for certification for update every 2 years. And that also includes should the research significantly change any time within that 2-year period, that the PDA may also be considered for re-review at any time during that time. And or also at the discretion of the medical director if we have the knowledge that the information has changed. And we also have the authority to withdraw or suspend certification at any time if we feel that that's needed as well. And you can, as I mentioned before, you can request it to avoid expiration. We ask that you do it no later than 6 months prior to the expiration. So I talked a little bit about some lessons learned from round 1 and what we know today. So those of you who submitted, know it took us a while, so we recognize in order to be very thorough, we needed to allow more time for the review process and debrief of members. That took longer than expected. We felt that that was mostly due to the fact that those on the review panel were not as aware of and knowledgeable of the certification criteria as we thought they were, so we needed to spend more time with them and bringing them up to speed on what that was. We heard from the development community that they wanted more time for the submission window. We only had 45 days the first time around, so we're doubling that this time. We've also been hearing that there's a lot of interest in submissions from other topic areas. We wish we could take them from every topic area that people have been developing them. Right at this moment in time, we're still feeling like we're refining this process, and until we feel like we have a really good process in place that we're comfortable with, we don't want to just open it up to everything yet. And also, as Dan mentioned, that N2F is in the process of developing a national certification process, which we hope to leverage that in the future as well. So we've been helping with that, and they're really looking at Washington State, and they've been leveraging a lot of the work that we've done in this state. So our second call, and probably what everybody's been patiently waiting for, as you know, round 1 we've asked for decision aids that address maternity health, specifically labor and delivery. Round 2 we're asking for decision aids that address joint replacement and lumbar fusion. We specifically put this definition up here because it follows the BRE recommendation. And so we put a link up here and in the email we sent out so that you could really understand what that means. But we also have Dan on the call today so he can answer your questions about what it is that we're trying to do with this. All of the work that we're doing around the certification of these decision aids right now and shared decision making, it's really focused on our accountable care program right now, and we're testing these within those pilots. And so these are some of the areas that they're working on. So this is why we're specifically asking for these right now. Also in round 2, we're going to continue to keep it open for those decision aids that address maternity health. So that's not closed. So from this next round in on, we're going to allow developers to submit decision aids that address maternity health. In the past, we've talked about the cost. Washington State law enables and requires HCA to charge for PDA review and certification. As we've mentioned before, it's our intention to keep the cost as low as possible. And we have not, up to this point in time, charged. We're still, like I said, we're still trying to get a process that we feel very comfortable with, and we feel is a good process before we start looking at charging. And we're also considering waiving fees for decision aids that are available to the public without charge. And so for the next round, we're still not asking for any fees associated with this as we continue to assess the actual cost to do this work and refine our process. So our next step, we're requesting submissions in early January, specifically January 3rd to be exact, and it's open for 90 days through March 31st. And as usual, the time frame for the review process is based on the number of submissions received, with our priority given to the joint replacement, but also if we receive the maternity, we'll review those as well. So on January 3rd, we'll post a copy of the final application document on our website, similar to what we did last year with application instructions. And we'll send out a link to everybody who signed up for the webinar today, as well as our typical stakeholder list. However, you can also go to our shared decision-making website to see the certified aids that are posted now and also to get any updated information. You can also send any questions. We have a shared decision-making email box where you can send them directly to me at that email right there, or you can call me directly at the number listed there as well. So now we're going to open it up for questions. We have a couple that have come in already.
Yeah, Laura, this is Dan. I just wanted to clarify one thing around the call for joint replacements, and that is for knee and hip joint replacements.
Thank you, Dan. Appreciate that. So please submit your questions using the chat function. We have 2 questions that have come in. And the first question is, will the HCA require the use of certified patient decision aids in its ACO contracts? Now I'm going to direct that to Dan.
So we do not currently, and at some point that's a possibility, but not for the time being. No.
Thank you. And then our next question.
I think where they're available, we will encourage it, but we won't. It would not be a requirement.
And if I could add to that, Dan, when working with the 3 sites that are enrolled in this, I know there's a lot of interest in the use of the certified aids. So I can tell you the interest is there, but I know we are also limited by the number of certified aids we have as well. I think possibly as we tend to get more inventory, maybe that could also have an impact on our ability to require as well. So the next question is, what is your sense of what impact the election will have on the state SIM funding through CMMI? Do you want me to take this one, Dan?
Go ahead, Laura.
So what we've heard so far is business as usual. We have not heard any different. What I can tell you is we're very fortunate in Washington State to have a bipartisan state that supports the work that we're doing. At the national level, we have not heard any different. And so it's very unknown at this time, but we've heard that there's a lot of support for this work. Dan, do you have anything different or anything to add to that?
No, you know, right now the ACA is the law of the land, and you know, and CMMI is there funding us, and we continue our work.
Any other questions? So we're going to take another minute to allow questions to come through. Asking. So we do have one other question, and Lori, please let us know if this is not what your question was. The question is, why knee and hip and not other joints? Why are we just asking for knee and hip?
Right. So that's a good question. You know, I think there are a couple of reasons. One is that you know, the work we're doing at HCA, we are aligning with the recommendations that have been made by the BRI, and so the BRI Collaborative. And the BRI Collaborative's recommendations around, with respect to joint replacements, the bundle that they have created, focus on knee and hip. So I think that is first and foremost the reason. That, you know, I think as well, they're the most commonly done joint replacements. So just from a volume standpoint. So those are the reasons.
Thank you, Dan. The next question is, are there ongoing efforts to better track shared decision-making use through EMR systems in Washington? Electronic.
Right. So you know, so that's a great question, and the answer to that is that there are not right now good ways to track SDM in the medical record. And for folks who are on the phone who might have participated in the ARC training that we had now a little bit, almost a year ago, is in February of this year. Actually, Kim Wickland, who's done a lot of this work at Group Health, and Group Health is, you know, being a leader in this work, spoke to that just in terms of, you know, how do you measure whether or not and the extent to which shared decision making is actually happening. And I think that, you know, that is in terms of the measurement piece, that is at sort of at the cutting edge of where this work is at. So I'm not sure anybody has developed really a good way of doing that to be able to measure the extent to which it's happening.
Thanks, Dan. Next question. So just to confirm, for spine, the priority area is lumbar fusion specifically, and not other spinal issues such as herniated disc and or stenosis.
That is correct. I mean, the stenosis and herniated disc are diagnoses. We're looking at fusion, and actually it's again, it's consistent with the BRIE focus, which is for people with non-complex spine. So what I refer people to, I think, in our call for for decision aids, that we actually explicitly sort of call out the language from BRIE, and I would guide people there. So actually, I just brought it up here. It's for persons considering lumbar fusion who meet disability criteria despite non-surgical therapy as defined by the BRIE Collaborative lumbar fusion bundle. So and that is we have a website that you can link to that gives more fuller description.
Okay. So here's a follow-up to that question. It says, why are you asking for PDAs specific to procedures like fusion or replacement versus PDAs for all treatment options for hip or knee pain, etc.?
Again, this is what we're focused on are people who are considering having one of these procedures, fusion or a joint replacement. So it is it is in that context, and appreciate that there might be alternatives, evidence-based alternatives to management of joint pain for somebody with osteoarthritis of the knee or hip, let's say. But and at some point we may well have a call for decision aids around those other approaches. That's just not the focus here. And as Laura I think pointed out earlier, we have a limited capacity right now to be reviewing and certifying aids. So hence the focus.
And I would add, this is Karen, that this call would be, it's aimed at people for whom lumbar fusion is one of the possible alternative treatments. So that means, that would be in the context of other possible treatments or medical management of that condition as well. So it's aimed specifically at persons who may be considering lumbar fusion and other medical management or other options for treatment of their condition.
Thank you, Karen. So the next question is, what if the tool addresses a broad service such as polypharmacy management, which can impact the areas of maternal health, etc.? How likely do you think such tool will be eligible?
Not exactly sure what the specific example is there, but what I would say is that we're really going to be focused on the specific decision context here. So again, while there could be alternative approaches that where you might have a decision aid or such as medication or certain kinds of medication or what have you, we're we're at a point, we're not at a point where we can sort of consider all of those. So really it is more narrowly focused on the topics as we've discussed.
So there's one other question, and it says, is there a reason you are not using a known vendor who has already created shared decision-making tools for a number of procedures?
Well, I think what we want to be doing is considering any decision aid that anyone, a vendor or a member of the academic community might have created. We're not going to restrict ourselves to any particular entity in terms of applying the certification process. And actually, I think from our standpoint, I would say that we actually are interested in in certifying as many decision aids as meet the standards as possible with respect to a given topic. We recognize that there can be some variation across aids that address a particular topic. That is, aids can have somewhat of a different feel to them and still pass muster, so to speak. And I think in an ideal world, we would love to make an array of such aids available to the certified aids available to the community.
Right, and I would also add that part of the reason to encourage the diversity through the certification process is that different populations have different needs, and different clinicians and provider systems have different capabilities and preferences. So some, for example, may prefer a decision aid application that can be directly integrated into their electronic medical record and supported by online tools and tracking, and others prefer different approaches. And the statute is written to accommodate those things, and the certification process is as well.
Thank you, Karen and Dan. So I think we have another question. It says, can you provide any information on when fees will be associated with the certification process and what the fees might be? So as I mentioned before, I think we're really just trying to understand this process and understand it well. Understanding what it takes to coordinate this within identifying experts to review this, who are the right people, and how to make this the best refined process. So part of that is really trying to understand how much time it takes for staffing. And so I guess I really don't have a good answer to this question. Probably if we do this another round before the national certification process gets in place, I would think maybe the next round we would have a good funding model in place for that and have a better idea of based on the type of aid that's being submitted, how much it may cost. But with that said, I can't promise. So, Dan, I don't know if you had any, or Karen, if you had any other thoughts on that.
Yeah, I was just going to say, Laura, I was just going to say, I think at this point we just don't have enough information really even to know when we might have an idea. So we're very early on.
And I would say, the overall intent would be to address the reasonable additional costs of certification. It's not a profit-making venture, and I mean that's just an expectation once funding is available also to help support, is that it would be based on some estimate of reasonable charge. But in order to get that in place, these first rounds where we're looking at what it really takes to do this well and economically are important.
Thank you. Any more questions? Okay, well, thank you all very much for joining us today, and please feel free to reach out if you have any additional questions. And as we mentioned before, the application and instructions will go live on January 3rd on our website, and we will share that information with those of you on the webinar today as well as our listserv. If you'd like to be added to that listserv, please shoot me an email at one of the email addresses listed on the slide. And thank you again for joining us today. Dan or Karen, any last comments?
I don't think so. I appreciate everybody's attendance and participation.
Great. All right. Have a great day.